Quem que é essa Ana Lúcia?
Não sei, deve ser do grupo. Hi, professor.
Sorry, I was on mute. Good
Eu não consegui
evening.
aceitar a
Good evening.
professora Paula.
Oi.
Evening.
Hello, Kevin. Good evening.
Hello, Paula.
Hello.
How are you?
I'm good. Hello, Pollyanna.
Oi, pessoal. Boa noite.
Hello.
Boa noite, professora. Estou tentando aceitar o restante aqui do
Jose is
pessoal.
there.
Acho que só pedir para o pessoal desligar a câmera, né? Para ficar só o professor Kevin e a professora Paula. Zé, eu vou apertar o botão aqui.
Tá bom. Essa Ana Lúcia aqui, ela é grupo, professora?
Não sei. Eu não sei, mas foi aberto o convite, não ficou aberto para todos, não só para o grupo de pesquisa? Todos vão entrar pelo Zoom,
lá,
né?
lá no YouTube,
Que agora
professora.
estão todos, né?
Para todos.
Tá, pelo YouTube, tá.
Isso, tá entrando.
Bom.
Hello, everyone. I would like that close to camera to microphone. Understand me? Peço para que todo mundo fechem as câmeras e os microfones, por favor, e fique só da professora Paula e do professor Kevin, por favor. Hi, Professor Kevin.
Nice to see you again, Jose.
Nice. And you? Professora, eu posso deixar já para a senhora iniciar?
Podemos começar?
Podemos, a transmissão já está para o YouTube também, né? Acho que nós podemos começar, então. Eu vou fechar minha câmera, tá bem?
Tudo bem. Então, boa noite a todos que nos assistem. Muito obrigada pela participação. Eu vou apresentar o professor Kevin em português, tá? A palestra vai ser em inglês, mas vou apresentá-lo, então, em português. O professor Kevin é enfermeiro, especialista em cuidados agudos e estomaterapia. Ele é mestre em ciências e doutor em filosofia na área de enfermagem. É professor titular na Escola de Enfermagem de Reabilitação da Queen's University em Kingston, no Canadá, e é editor web da Advances and Wound Care, representante do Canadá na STAP e é professor visitante do PROESA, nosso programa de pós-graduação em enfermagem na saúde do adulto da Escola de Enfermagem da Universidade de São Paulo, é co-orientador de doutorado da Carol, né, de uma das integrantes aqui do grupo de pesquisa em estomaterapia da EUSP, e é um pesquisador de excelência na área de estomaterapia, especialmente na área de feridas, e hoje, então, ele vai apresentar a palestra Gaps in Stomatherapy Nursing, e depois da palestra vocês podem fazer as perguntas que a gente vai abrir aí para uns minutinhos para pergunta. Então, professor Kevin.
Great, thank you so much.
Okay, thank you so much to be here with us. I introduce you in Portuguese for to the audience, and now you can start your lecture, please. 1 hour, and after that we open for some questions. Thank you very much.
Okay, great. Thank you so much, Paula, for a introduction. And thank you so much for having me to lecture in the evening. I'm sure everyone has a very long day already. So I'll try to make sure that I finish my talk in an hour. Now, I am not able to share my screen, Jose. You have to change the settings so I can share my screen.
Can you see the share screen in the
It said the host disabled participant screen sharing.
Okay, let me see. Alguém pode ajudar aqui que eu não estou conseguindo dar permissão? Eu cliquei aqui, mas aparece que eu não estou habilitada para compartilhar. Fala que eu estou hot disable participant screen sharing. Only a minute, Professor Kevin. I can see.
No problem. I'm still here.
Okay, let me see. José Luiz ou Carol estão aí para me ajudar? Alguém pode me ajudar? Vocês estão me ouvindo?
Consegue? Deu certo?
Não deu certo. Como que faz para ele compartilhar a tela? Porque quando eu fui aqui autorizar, para mim apareceu que eu não estou habilitada.
Ele precisa ir no canto da tela, no fim da tela
mas ele fez isso, mas ele também não está habilitado. Alguém precisa dar permissão.
É que não apareceu para que eu desse a permissão para ele.
Com quem a gente pode ver isso?
Só um pouquinho que eu já estou tentando identificar aqui, professora.
Que para mim está aparecendo desabilitado, ô Carol. Eu não estou conseguindo dar permissão para ele compartilhar. A Carol está me falando que quem seriam os hosts é o José e a Laís. Então, vê se vocês conseguem dar permissão para ele. Eu acho que aparece ele Professor Kevin, did you ask permission to share your screen?
Permission. Let me see.
When you click in share screen,
yep.
What
no,
happened?
It doesn't ask me. It just said host disabled participant screen sharing. So
okay, it's the same to me. When I click in share screen.
Yeah.
José Luiz and Laís are resolving this problem.
Okay.
É o host que tem que dar permissão, no caso é o José Luiz, ou a Laís, que a Carol falou.
É que eu não consigo identificar o nome do professor Kevin aqui. Eu já cliquei onde é New Share, né, para poder aceitar, e não aparece aqui para mim.
Não aparece o nome dele? Professor Kevin, José Luiz and Laís are the hosts. Eu não mexo nesse Zoom, gente, eu não sei onde vocês clicam, mas é o host que dá permissão, né? Teria que aparecer o nome dele para vocês darem permissão. Só um minutinho, pessoal, estamos resolvendo esse problema técnico.
Só um pouquinho que eu estou procurando aqui, tentando...
Maybe,
Okay,
Professor Kevin, if you send me the presentation, maybe I can share for you.
I can share it now, actually. Can you see the screen?
Yeah, my email is
Can you see that? I think I'm sharing that right now.
Yeah?
Can you see it?
No.
No?
No. I can't see.
Meu Deus do céu, deixa eu tentar aqui.
So...
No?
José, a Carol falou que você precisa dar permissão para múltiplos compartilhamentos.
Sim, eu estou procurando essa permissão e ela não está aparecendo para mim. Eu não sei se é a minha tela, de repente, que está faltando alguma coisa.
Isso também não aparece?
Lá no share screen, eu dei na minha parte, mas eu acho que o Zé precisa dar também. É no share screen, Zé. Aí você vai na setinha e coloca.
Múltiplos compartilhamentos.
You are screen sharing, é esse?
Isso, e aí tá aparecendo que ele pode, que tá certo.
No, you cannot see my screen?
Not yet.
Not yet, because I am sharing the screen right now.
Yeah.
As I
Vocês
can see
veem a tela dele, gente? Vocês estão vendo?
Okay.
Eu não estou vendo.
All right, I will send you the presentation.
Vocês conseguem ver? Não, ou não? Gente, falar comigo, por favor.
Zé, volta lá para a sua tela do Zoom, da reunião.
Ah, sim, eu estou tentando.
Obrigada, Raquel. Zé, clica no share screen, faz como a Laís te falou.
Want me to try?
Yes, Professor Kevin. Yes, now I see your screen.
Okay, perfect. Okay.
Thank you very
All right,
much.
a little bit
Sorry
technical problems. Yes, no worries, no worries. I think we have fixed the problem. So again, thank you so much for having me to present to you today about the topic that they have given me is about gaps in ostomy care. I think this is a very interesting topic that we don't often talk about, and that's why that's the impetus for us to have a focused discussion on some of the gaps and trends in ostomy care. So as Paula introduced earlier, my name is Kevin Wu. I'm a professor at Queen's University from Canada. Welcome. And right now, the temperature is actually colder in Brazil than in Sao Paulo than in Toronto. So I'm enjoying a little bit cool air at the moment. So I just want to also acknowledge the contribution of Tarek Alam to help me with this presentation as well. He is a very nice colleague and friend of mine, and has been working as a NSWOCC, a ET nurse for a long time. And also he was able to help me to get some new ideas about what to present in terms of the gaps in ostomy care. So as you can imagine, ostomy continue to be very common in North America, at least. I don't exactly know the prevalence in Latin American countries. At the moment, approximately about 1 million people in North America has ostomy. And you may imagine with so many people with ostomy, they should not be having any complication. But I'm surprised to see that about 7% of individuals with an ostomy continue to experience peristomal complication at some point during their whole lifetime having an ostomy, living with an ostomy. So I think this is a major concern for us that as nurses, we need to address this problem and see what we can do to reduce some of those complications. As you can see on the second bullet here, in Canada, some of the prevalence studies indicate to us colostomy individuals with colostomy are more likely to experience problem, followed by ileostomy, about 38%, and also urostomy in 12% of individuals with stoma. And we don't know exactly why individuals with colostomy tend to have more problems with complications, perhaps because of the surgical techniques and other issues. So I think that's another area that we probably need to do more research, comparing why individuals or the experience of living with a stoma, whether there's a difference between colostomy individuals and ileostomy people. And about 60% of the stoma are temporary in Canada. Often they may be reversible, but still they need to experience living with the stoma for a duration of time. And perhaps that is a big gap in terms of education and promote adherence. A lot of times when I work with individuals with temporary stoma, they don't really listen very well. They don't want to care for the stoma. They don't even want to look at a stoma sometimes, because what they're thinking is, well, I'm not going to be living with this for a long time or permanently, so why should I learn anything about stomal care? And that's potentially is one of the biggest concerns I have for individuals who have a temporary stoma. And this is some of the literature, and we probably need to review and revise some of the literature. And as you can see, there's been a lot of different studies conducted in North American countries to evaluate the different types of peristomal complications. And I would love to see more studies done by Brazil. And because you have such a vibrant community, research community, and we'd love to see more studies being published by Brazilian nurses to indicate to us or tell us what are the complications, what type of complications people live with, so we can actually develop educational programs, develop better products, better programs to address some of those complications and problems. As you can see, a lot of times people experience peristomal skin issue, and that's why we need to pay more attention to that. And I'll come back to talk a little bit more about the different types of complications, which I think most of you have heard about them already, because a lot of the audience here, you are ET nurses or stomal nurses. So this is not a new information for you, but I thought that it would be nice to refresh your memory about some of the common peristomal complications. And of course, what we want to do is to make sure that we address the peristomal skin. We want to make sure that the skin continue to be intact, despite the type of stoma they have, the duration of time they have the stoma, and also different types of appliances and devices they use to manage their stoma. And a lot of times we may see mild, moderate to severe different types of peristomal skin complication or PSCs. And to this day, I don't think there's any good standardized tool to evaluate and also to categorize and document the different types of the severity of peristomal skin complications. There's been a lot of tools in the past trying to characterize, qualify the different types of injuries, but I don't think we actually have made the attempt to describe the severity. Just like pressure injuries, we can describe them in the stage 1, 2, 3, 4 with the different tissue involvement and describing the severity of the pressure injuries. And we can predict the healing time for different types of pressure injuries. But for peristomal skin complications, it doesn't work in the same way. And that's part of the impetus for us, perhaps, to really think hard to create some standardized lexicon and terminology and ways to describe different types of peristomal skin complications and also to describe the severity. The complications can be divided into 5 major categories, whether it's chemical injury, mechanical injury, infection-related problem, immunological disorders, and disease-related disorders as well. Just a quick review of some of the common problems and solutions that we come up with. For example, one of the major and most commonly reported complication is irritant contact dermatitis, a chemical injury. Dermatitis can present as erythematous, moist, painful, and shallow peristomal erosion in areas where the agent contacts the skin. The irritant may include mucus, urine, fecal material, and skincare products. So I think we're all quite familiar with this, and some of the tools will describe the extent and the different types of characteristics, how erythematous the skin is. And again, I challenge all the audience in this webinar today is to come up with a better way of describing the severity in the future. The management of irritant contact dermatitis may include removing and addressing offending agent. I think that's probably the most reasonable way to address the problem. If we remove whatever is causing the irritation, perhaps we can reduce the severity of those types of dermatitis. We can protect the skin. And as you're aware, a lot of the protectant barrier may not work under the appliance because it may affect adhesion. So that continues to be a challenge for us to present those issues to industry partners so they can create or manufacture some specific product and barrier that can be used under the appliance, doesn't affect adhesion. And in some cases, we might apply topical anti-inflammatory products at the pouch change. Again, in my country, in Canada, we don't really have any good topical anti-inflammatory agents. We may use steroid, we may use some other agents, but when we use cream and ointment with anti-inflammatory property, that can affect the adhesion, and that can affect the wearing time of the pouch. So I think that, again, we need to have better product and better protocol to address irritant contact dermatitis. The other type of chemical injury is what we call the Pseudovaricus lesions. the benign thickened epidermis with white, gray, brown, or dark red papules or nodules in areas chronically exposed to effluent and causes sometimes hemorrhage, and definitely it could be very, very painful as well. So it is, I think, underreported in most cases that we see that from time to time, but people are not really diagnosing that correctly. And we need to do more education for the general practitioner to really identify those issues so they can refer to specialized people like us to address the problem. The management, and partially, is because of the looking at the etiology, why those lesions develop. We might want to resize the ostomy barrier or flange to protect affected area. We can increase appliance change intervals until improvement noted. And of course, this can have a direct impact on the cost and the self-care abilities. I think appliances are very, very expensive, whether it is in North America or in Latin America. And government we continue to canvass for more funding from the government to provide more support for ostomies, for people living with ostomy, so they can have the resources they need to address some of those issues. In some severe cases, we may use sulfonitrate for considerable raised lesions or bleeding lesions that are not managed well. And this may be an area that may require some more research to determine whether sulfonitrate or some other anti-inflammatory dressings with sulfur component may be able to reduce the inflammation and reduce the bleeding problem. Chemical injury may also include another condition called alkaline incrustation. It basically, we have crystal deposits on exposed peristomal skin. It's a complication unique to ileocondyli. And stone bleeding may occur when crystals are manipulated and also irritating the skin. And there's been a lot of different proposed strategies to address alkaline incrustation by acidify the urine. We can increase daily oral fluid intake and acidify urine with ascorbic acid, for example. 1 gram of vitamin C is recommended in a lot of best practice recommendations. We may also use vinegar soaks at each pouch change to assist the incrustation to be removed and dissolved over time. So switching gear a little bit to look at mechanical injury, people can develop pressure ulcers around the pouch. Pouching system may apply too much pressure, resulting in tissue damage. And especially when we think about some of the some of the pouch with convexity, and by applying the appliance incorrectly or with too much convexity may sometimes predispose the skin to pressure injury. The other type of mechanical injury may include skin stripping. Stripping injury can cause erythema with scattered lesions lacking the epidermis and often corresponds to adhesive surface or its borders. And especially with more frequent changes and the frequent removal and peeling the skin can strip away the epidermis, causing further damage. And mechanical injury can go hand in hand with chemical injury. By mechanical injuring the skin may become more vulnerable to chemical irritants and the penetration of chemical agents into the deeper compartment of skin. Another type of mechanical injury is what we call the Mycocultaneous Separation. This complication is an interruption of the suture line with skin separation at the mucocutaneous junction. It occurs in approximately about 12% of fecal stomas, so it's a relatively common problem. The etiology may include compromised healing, infection problem, a large skin opening, poor surgical technique, and excessive tension at the mucocutaneous junction. We probably need to do a little bit more research in this area, and because it's a very big, lots of risk factors that can predispose people to develop MC separation. Perhaps we need to identify what are the most common problems, especially some of the problems are highly preventable. poor surgical technique. Can we improve the technique? We need to go back to talk to our surgeon colleagues to address some of those issues so we can prevent MC separation in the future. Whether it is mechanical or chemical injuries or excess moisture, it can predispose pathogens we can enhance the pathogens proliferation on the skin level. One of the most common problems is fungal infection or candidiasis with yeast. It can present as pustules. In patients with this problem may complain about pruritus, itching, burning sensation. Antifungal powder has been applied or cream applied to the involved area. That's, as I said before, any type of cream and ointment can affect adhesion, could be problematic. And in Canada, we don't really have a lot of antifungal powder available. And remember that whether we're addressing fungus infection or fungal infection or candidiasis, different types of antifungal agents may be required. In some severe cases, systemic antifungal agents may be needed. What about folliculitis? Because of the repeated removal of the appliance, and it can irritate the hair follicle, exposing some of the dermal layer, and it can predispose individuals to develop infection problem and involving the hair follicles. In this case, the most common pathogen causing folliculitis is Staph aureus, present as erythematous lesion at the base of hair follicles. Pustules may also be noted at the base of the follicles and oozing, producing pussy material. Treatment may involve antimicrobial soap, clipping, and trimming of skin above the skin level. We don't recommend people to shave, obviously, because by shaving the skin, it can actually pull on the hair follicle, causing further irritation. What about allergic contact dermatitis as an immunological cause of peristomal skin complication? Allergic reaction to skin products applied with or composing the stoma pouching system adhesive manifest as erythema, itching, vesicles, papules, bullae, skin induration, and erosions. So a variety of presentation that we see may develop because of allergic reaction. Keep in mind that allergic reaction is not very, very common. Most of the contact dermatitis is because of irritant, not because of allergies. And patch testing may be useful to identify the specific allergen that is causing the problem. Approximately, the incidence is about 1.6% over 3 years, so it's a very rare problem. But they do occur, of course. What about varices? That's probably in relation to disease problem. Varices occur secondary to portal hypertension, people with liver disease. They can develop portal congestion, and with the congestion, with the pooling of the blood, a lot of the veins can be dilated, causing varices. And on examination, varices can present as purple skin discoloration with dilated tortoise pain veins on the stoma. Veins are vulnerable to bleeding. It can be damaged very easily. That may require protection of the mucosa. Another type of disease-related complication is pyoderma gangrenosum. We know that this is a rare condition, it's not very common, but among stomal patients, this may be a little bit more obvious for us because pyoderma gangrenosum is related to some of the common diseases among individuals that require a stoma. For example, individuals with inflammatory bowel disease, people with hematological disorders. So that's why a lot of times when we take care of patients with Crohn's disease, they can develop pyoderma gangrenosum very easily. So they're painful, inflammatory ulceration skin. You often recognize the lesions by identifying the purple color border. The fancy term we use is the verruculous border, and they may be raised because of the inflammation. And the challenge, as you may be aware with pyoderma gangrenosum, is the pathogen problem. So meaning that even with minor trauma, it can actually increase and trigger an inflammatory response and allowing a small lesion to continue to grow into a bigger skin problem. So you can imagine when we're changing the appliance, changing the flange, it can cause further trauma, and that can trigger further inflammatory response. So I'm not quite sure there's actually good literature and good recommendations how we can address and reduce the trauma so we can avoid pathogen among individuals with powder megagrainosum. So overall, the newer terminology and new classification system is we divide them into the PMASD, the peristomal moisture associated skin damage, versus the PMARC, the peristomal medical adhesive related skin injury. As you can see, the PMASD is it usually involves the skin exposed to external moisture, such as stool or urine, and may result in dermatitis, maceration, or fungal infection because of the moisture. Versus the PMARC, the peristomal medical adhesive related skin injury, they're usually discovered underneath the adhesive material. And recognizing also that both conditions can coexist at the same time. In the last couple of days, I had the pleasure to listen to some of the research presentations from different clinicians and students at the university. And one of the projects involved looking at how we can identify the risk factors associated with moisture damage versus adhesive-related skin damage. And that's not always it's not an easy task, because there are a lot of overlapping characteristics. And until we can identify the etiology, get a good history, by looking at the skin itself may not always point us in the right direction. But nonetheless, those terminologies, those classification systems can help us to really identify some of the major interventions that we need to develop, we can evaluate and examine so we can address and prevent some of those issues from happening. So I want to address the gaps in ostomy products for a second. Over the last few decades, ostomy products continue to evolve. And this is a nice diagram to show you from the early 20s, the very primitive way of managing stomal care, and the first the pouch actually developed by Dr. Alfred Strauss in Chicago. They developed a rubber pouch system. Obviously, this is very primitive, very difficult to wear, and there's a lot of adhesion problem. And over the duration of time, the course of time, there's some new development, new formula, new material that has been developed. And part of the gap in stomal research is the lack of evaluation of different types of skin barrier that we can use to reduce skin complications and irritation around the stoma. Recognizing this is one of the major problems, whether we can manage the moisture better or reduce the adhesive-related injury. Despite the progression in stomal products, the incidence of PSC continue to be extremely common. I just want to impress on you the high frequency and prevalence of PSC in the literature. Up to 75% of ostomy patients have peristomal skin complications. Very, very common problem. And the sad news, a lot of times individuals living with stoma, they may think this is part of the normal process of having a stoma, so they don't always report the problems and seek help from health professionals like you and I. So they thought that this is just a normal part of having or living with a stoma. So that's part of the importance of providing education to families, to patients, so they can identify the problem early on. By addressing the problem earlier, we can prevent some of the really severe complications from happening. And I think this, again, is the really reiterate the point that a lot of times people think that living with a complication is part of having a stoma. So only 1 in 5 patients will seek treatment and help from us. Treating stomal skin complication is very, very complex, PSC. It requires a lot of time from us. And that's part of the research that we need to work on to really capture the time intensity, the nursing intensity around the management of PSC. The second thing is ostomy accessories. What are the type of material that we can use to prevent stoma-related skin damage? What about topical medication? As I pointed out a few times early on, whether we're dealing with fungal agents, whether we're dealing with inflammation of the skin because of dermatitis from irritants or allergies or allergens, a lot of the topical medication may not be ideal. So we need to look at better topical agents, whether to enhance skin quality to prevent some of those complications from happening, or some of the more effective agents that doesn't affect the adhesion of appliances. Ostomy barriers, absolutely. And I think I have a slide just to illustrate that we have a lot of research looking at dressings for wound care and evaluate different types of dressings and how effective they are in terms of addressing problem, whether it's infection or wound healing. But in terms of stomal care research, we don't really have a lot of nursing-generated research to evaluate the different types of barriers. It's one better than the other. The other complication, of course, is hospitalization and health service utilization. And when you look at the different types of complications listed here, what we can appreciate is the cost associated with the different variety of PSCs. As you can see, the more severe some of those complications are, the more likely it will require a high cost to address the problem. And that's why we need to address the problem early on, or we even prevent some of those problems from happening. And I'm actually surprised to see that granuloma could be very, very expensive when there's a severe granuloma developing in the peristomal skin area. The cause of the peristomal skin and the many different cause factors, whether it is obvious to us or some of the hidden causes. And as you can see, again, depends on the severity. People with very severe PSC are more likely to require a lot of resources, and it can increase the amount of cost by 6 times compared to mild PSCs and 4 times compared to moderate PSCs. And if you think about the different types of injuries associated with PSCs, and what we can see is in the bullet here, 43% suffered from mild PSCs, and about 42% moderate, and 15% was severe. And yet the individuals with severe, they're more likely to consume a lot of costs and resources in the health system. And what you can see on the table here, separating the different types of complications and the severity, and you can see that the cost associated is just phenomenal. Those are staggering statistics from France. We also know that because of the complications, people are more likely to require rehospitalization. They're going back to the hospital more frequently, more often because of the PSC issue. And they may require, when they're in the hospital, they may stay in the hospital for longer duration of time. So I think that's definitely pointing out the reason why we need to develop better programs better products and better approach to prevent and manage PSCs. So now I hope that that you're all thinking about different types of research questions and perhaps solutions to reduce skin complications, to reduce unnecessary visits to clinicians and hospitals and clinics, and also allow people to keep on working. Because one of the hidden costs that we don't really and not very easy to capture is when people experience some of those complications, they may not be able to work, they may not be able to return to the work environment. It can affect their social life, the quality of life. And that is one of the major problems associated with PSC. And of course, you are the expert. I think I have Professor Vera's picture here because she is really the pioneer of looking at quality of life research among individuals with stoma in Brazil and in the world, I would think. So I think there's been a lot of great research generated from this country, and I congratulate you on doing all this great research, but there's still a lot of work need to be done. So one of the major focus now shifting a little bit, not just about quality of life, but also measuring health utility. And I'll share with you some of the studies. What health utility, how is it different from quality of life? Health utility is defined as preferences that individuals have for their health state and health outcomes. Not always in dollars and cents and in terms of a financial number, but looking at what they really want. They want to go back to work. They want to be able to enjoy sex. They want to really be able to look after grandchildren. That's part of the idea, the conceptualization or the operationalization of health utility. Those are important outcomes, patient-oriented outcomes that we need to focus on. And in wound care, we start to talk a little bit more about what are some of those outcomes. And there's been groups of people, and I'm working with a bigger group of international experts on developing and doing some scoping review to look at patient-oriented outcome and performance indicators for wound management. But we don't really have a good sense and good idea about health utility, patients' preferences, and oriented outcomes or outcomes oriented to individuals who are living with ostomy. So this is one of the big gaps that we need to understand what's important and what's relevant to our patients living with stoma. And of course, some of the major components, it could be part of quality of life from a physical, social, cognitive functioning perspective, psychological well-being and symptoms, including pain. And often we, from a professional perspective, we expect people to do certain things, expect people to be able to function at a certain level. But what we don't understand is what is the optimal level that patients would desire? What are the key indicators that would be relevant to individuals living with ostomy? So there are different tools that we can use to evaluate the quality of life and health utility. The metric is a combination including the length of life and also the quality of life. So just to show you some of the research here, and based on some of the most recent documentation and published material, that when you look at people without a stoma, so the health utility on a scale, if you think about convert into an index, it could be converted into a number from 0 to 1. So 0.74 is relatively good, 0.74 for individuals without a stoma. And what they have seen overall, people with a stoma, with a healthy peristomal skin, their quality of life, the health utility is actually not as bad. It's 0.75, very similar to individuals without a stoma. So you may think, well, we're doing very good, right? But keep in mind that this may suggest to us that most people with ostomies may have adjusted to the stoma, and they continue to live a fairly normal life despite some of the challenges and complications they experience from time to time. Now, this is not to say that they don't experience complications, that they don't experience all the complications, but it just indicates how resilient our patients are. So there's still more work needs to be done to really help us to understand how we can address this problem more appropriately. And also keep in mind the indicator, the 0.75, really focusing on individuals with uncomplicated ostomy, with no issues at all. When people develop different types of PSCs, peristomal complications, depends on the severity. Look at the health utility index. It's really going down from mild 0.69, moderate to 0.64, and severe PSC really compromising individuals' health utility and quality of life down to 0.58. We compare to other disease states in the literature, you can see that people with severe PSC, their health utility score is very similar to individuals living with severe heart failure. If you remember people with heart failure, they cannot walk, they're huffing and puffing, they have breathing difficulty, they may not be able to enjoy life that much. It's really, they experience a lot of symptoms and complications. And that's really mirroring, if you think that people with peristomal skin, maybe just around the skin. So, but still, it has a significant impact on their quality of life. Even worse than individuals with the first recurrence of breast cancer. So you don't need me to tell you the benefits of healthy peristomal skin, because obviously it can reduce the healthcare utilizations and resources that are required to look after those problems. It can improve social connectivity, recognizing that people with some of those problems, they have leakage, they have pain, they have discomfort, they have other worries that can affect their social interactions and creating social isolation problems and affecting the relationship with their families, with their partners, with their co-workers. And the other benefit is by promoting healthier peristomal skin, we can improve our efficiency. So we can spend more time to really address the real problems and also to look at, to spend more time doing more research. We can also reduce the product utilization and be more cost effective in reducing the financial burden on our patients and the system. And most of all, I think we need to think about health-related quality of life by addressing peristomal skin. So I think in summary, by maintaining healthy peristomal skin have many, many benefits. It not only helps to improve social connectivity and quality of life, but can also reduce healthcare costs and resource utilization in the healthcare system. So how can we address this gap? Well, that is a biggest gap, I think, and that's why I welcome some discussion and conversation around what we can do to address this gap. As I mentioned earlier, unlike wound care research, there's been very little research on ostomy products and ingredients and how some of those appliances and different types of devices that we use can impact on peristomal skin health and peristomal skin complications. I want to share with you some of the most recent literature, and they're really well done effort, literature and studies. This is called the Advocate Clinical Study. It's a trial provides important new information to address the knowledge gap about the management of peristomal skin and the cost advantages of these improvements. What they have done is to compare skin barrier impact on healthcare costs and peristomal skin health It is a randomized controlled double-blinded study comparing a ceramide-infused barrier with control barriers. I highlighted this study because, first of all, there are not many randomized controlled design studies really evaluating different types of barriers. And second of all, this is a very robust study with a large sample size. So I think it really created a challenge, raised the bar for researchers to be able to come up with better research design with better sample sizes to address some of those research questions. And what you can see here is the advocate study included participants who were 12 weeks post-surgery in a time that they are at high risk of developing PSCs. There were about 153 participants in the study, random assigned to either treatment group with the ceramide-infused barrier, and the other group is the control group. It's a double-blinded study. 90 participants or the investigators were aware of the group assignment. And there were 25 sites involved across the world. And it is a very interesting adaptive design to look at the differences between the two groups. And the study, the key results that were able to demonstrate that the ceramide-infused barrier has a positive impact on the stoma-related cost of care and the peristomal skin health by reducing the severity and also prevent some of the peristomal complications. Individuals with the ceramide-infused barrier has significantly lower stomal-related costs per patient over a 12-week period. We're talking about $36 US savings per patient. And you may think, well, $36 is not a lot of money. And even from from your standpoint, from Brazilian conversion standpoint. But when you think about the long-term effect and also the number of individuals who can potentially benefit from the intervention. The other important finding in the study is in relation to PSC incidence, the development of complications in peristomal skin area. More than 25% relative reduction in the number of PSCs in the ceramide-infused skin barrier group. So I think I think this is a very important message that we can prevent some of those problems and promote better skin health in the peristomal area. And with the use of ceramide material, it also improved healing time for the complications. 53% versus 29%. There's a significant improvement in the likelihood of resolving PSC within a 4-week duration among individuals using a ceramide-infused barrier. And the other study is to look at the connection between peristomal skin health and transepidermal water loss. There's been sort of different techniques and innovative way of evaluating early signs of skin damage associated with peristomal damage. And one of the issue is when there's early skin stripping or damage, the structure of the epidermis is altered in such a way that allow more water vapor to be detected by different types of machineries. And this is a study done to measure the epidermal effects of peristomal skin barriers. And what they have identified, the importance of peristomal skin health is very important. And there are different layers. As you can imagine, the epidermis, there are 5 different layers of skin cells. When they're disrupted under the skin barrier, whether it is from the repeated removal with the peeling and the skin stripping, or from other type of moisture-related problem. And that's why we need to think about better products. So they measure the skin integrity after ostomy skin barriers are removed by measuring the transepidermal water loss measured by a evaporimeter. And also there were trained observers involved in the visual examination and observation of the skin by grading the different severity of skin damage. So the goal is to determine differences in skin integrity between a ceramide-infused skin product and skin barriers without the ceramide. So what you can see is the transepidermal water loss can be measured in a controlled lab setting, and definitely there is some good literature indicating that with skin injury there is a higher TEWL loss. So in this study, the design involved 20 healthy individuals with a stoma, and they were experimented with the 2 ostomy barriers. The barriers were changed every 3 to 4 days for a total duration of 6 visits in 7 days. The skin observations and the transepidermal water loss were measured, and they were blinded in terms of the evaluators were blinded, so they're not aware to remove the potential bias when they're evaluating the skin. So looking at the results here, as you can see on this slide, there's a significant difference between the visual evaluation between the 2 groups, reaching a statistical level based on also the transepidermal water loss as well. And there's a difference in terms of degree of skin stripping and the severity of irritation along the edge. The ceramide-infused barrier was found to cause significantly less irritation compared to other skin barrier that individuals were using. And I don't mean to be promoting just one product or one type of skin barriers. I'm highlighting this because those are the only available the evidence that we have for discussion, and I hope to see more research being done in this area so we can compile more literature and have more discussion around different types of agents, not just ceramide. So anyway, overall comparison, there's less irritation in people using the barrier, using the ceramide-infused material over time. As you can see, the lighter color is the group with the ceramide, and the deeper color, darker color are the ones that in the control group, in the control environment. So you can see the increase in the complication and the irritation over time compared to the ceramide group continue to be relatively stable over time. Obviously, there's some limitations. Participants did not have stomas and were naive to ostomy skin barriers, and they have very small sample size in this study. But anyway, at the end, the authors were able to draw some conclusions that there were statistically significant differences between the 2 groups in terms of the assessment of the skin, except erythema. And there's also a significant differences in the transepidermal water loss between the 2 groups. So the conclusion is the ostomy barriers with the ceramide was significantly less disruptive to the epidermis, and by reducing the trauma upon removal of the barrier than ostomy barrier without ceramide. So I think, of course, the question is, what do we need to move, what the direction that we should move, and what's the next step? Oops, not quite sure why it moved by itself. So I think now you know the background, you know the problem, and you see there are some studies being done. So as we continue to move forward to advance the science, advance our career as ET nurses and peristomal nurses, we need to think about creating an environment that is conducive and that can promote intact peristomal skin. We need to think about different ways to provide better skin barrier, prevent dryness and itching, prevent infection and pain, how we can improve the quality of life among individuals living with ostomies, and also something that is financially responsible and does not put a burden on patients and the system. So I think when you think about historically, there's been a lot of, as I mentioned earlier, there's the evolution of pouching system. And now you see the evolution of skin barriers formulation from something very primitive to what we have seen in the past using Karaya. And we have identified that potentially can cause a lot of problems for people who have sensitization problem, allergies to rubber. Karaya may not always be appropriate. And then moving on to the use of hydrocolloid material, but there has a tendency to create more skin stripping and skin damage. So now the infused barrier, especially with ceramide material, that potentially can change the landscape of peristomal skin care and prevention. The other highlight I want to point out here is the peristomal herniation. The Canadian NSWOCC, the nurses specialized in wound ostomy incontinence, or your ET group, the SOBAS group here, is really working on a project to develop best practice recommendations for peristomal hernia. It's a common problem, and we don't really know exactly the best way to manage this problem, nor is there good evidence and summary of evidence to provide some cogent recommendations for us. And that's the impetus for our organization to look at the literature. They're currently using a scoping review methodology to summarize all the literature. I was involved in terms of the literature search to supply the group with all the material so they can use their critical eyes to determine what makes sense clinically or what makes sense from a scientific perspective. There's been a lot of discussion about whether diet can help to reduce the occurrence of herniation or reduce the severity of herniation. Exercise is another important strategy to improve the tone and also the muscle strength. Perhaps it can reduce the occurrence of herniation. Belt and other type of devices potentially can also help. But hopefully we will be able to come back and present the best practice recommendations to you in the near future. I think the goal is to have this project finished by the end of the year, and it will be published in probably JWCN journal. And if you are interested, please contact our association. So I think this is a quick tour and review of some of the common problems and gaps that, from my perspective, are crucial and important in a practice, and give you some ideas in terms of research questions, research areas, and how we need to move forward as we continue to develop better way of caring and reducing peristomal skin complications. All right, I'll stop here and see if there are any questions. I hope this presentation makes sense to you.
Yes, Professor Kevin, thank you very much for the excellent lecture. In the clinical practice, it's common to observe some complications, especially the dermatitis in peristomal skin. But in Brazil, there are few studies in this area in ostomy care, especially in ostomy care. So I know the barrier infused with ceramides or Hollister. I indicate a patient to participate in the study about this kind of barrier, and the result was so good, but it was a punctual study, and lots of patients do not have access to this kind of technology, this barrier, because the costs. So it's necessary a larger, big study. And in Brazil, the studies are so, it's necessary to do more studies about this. So thank you very much. There are some questions. One of the questions is, how many centimeters of peristomal skin are considered peristomal skin area?
I think that's an excellent question in terms of the area involved and the extent, so we can classify that as a complication. That's a very difficult question to answer, even though it sounds like a simple question, because it really depends on the etiology. Even if there's a small lesion that is related to, let's say, pyoderma gangrenosum, even when it's small, but it can have a huge impact on the individuals who present with the problem. Because for people who cared for individuals with PG before, they know how painful it is. They know how problematic it could be. So it's not, and that's my challenge to all of you in the audience here, is to look at, it's not just about the size of the issue, but also looking at the etiology. And a lot of times when we classify severity, we just really looking at the amount of skin involved. Yes, that may be one of the most obvious parameters, but there are other parameters. For example, the layers of tissue involved. How deep is the tissue involvement? And also looking at the type of problems, whether it is in relation to disease versus in relation to a contact dermatitis. So I don't think it's just about the surface area that is involved to be concerned, but also depends on the underlying etiology and the potential problems and the prognosis of those problems.
Thank you. The other questions, Carol has some questions. Carol, please, can you put the questions for Professor Kevin, or I can read?
Good night, everybody. Professor Paula. Hey, Professor Kevin. Professor Paula, as you wish, I'm just taking the questions from YouTube and from WhatsApp groups and putting them here. So if you want to read them, it's okay.
I can see them as well. Maybe I can read them out. So there are many barriers for research in nursing, as knowledge and lack of funding and ideas about how to do low-cost research and to motivate ET nurses to do research. Again, excellent question, and not an easy question to answer. I think yes, hopefully conversations like this would inspire more researchers to be involved in ET-related research and peristomal skin research type material. And funding is often a barrier because all research requires resources. I would love to do more research in this area as well. There are companies and industry partners that we can work with, and they're innovators and innovative technologies. And as I said in some of the slides I presented to you tonight, based on the ceramide infused material barriers, they're produced by companies, and we need to evaluate them more carefully before we adopt some of those technologies. And Professor Paula is right. Yes, they're very, very expensive, and most people may not be able to afford it. But let's think about cost effectiveness. If we can use a product for a longer duration of time, it's much cheaper than using a cheap product and you have to change every day and continue to complicate the problems. And that's why the conversation is about health utility. It's not just about cost itself, but also going back to what patients need, going back to what really relevant to our patients, so we can care for them in a different way. I don't think you need to take a lot of money to do research, and it takes some money, but it's not millions of dollars that we need to do good research. Even for some of the prevalence studies, even some of the studies that we can have a conversation with our patients, it can actually help us to understand a lot about peristomal care. It can help us to understand from a product perspective, what works and what doesn't work for our patients. So, I love to have that, to continue the dialogue and have that conversation. And definitely it is not something that is very, very, very expensive, unlike some of the drug studies. There's also a question about which research methodologies could impact clinical practice with the results in order to fill the gaps. So from a research perspective, it all depends on the research question. And what we have been talking about are interventions related research. The best approach to evaluate intervention is randomized controlled design studies to really show us whether intervention, treatment, it can be better compared to a control kind of environment. By doing RCTs, or randomized controlled design studies, that remove a lot of the biases, a lot of the problems that we see in cohort studies, in other study designs. Now, depends on the type of questions, depend on the resources you have. RCTs are not always feasible, and you need a large number of patients and participants in some of those studies to be able to demonstrate the power, to be able to evaluate the differences from a statistics standpoint. So, and I think they tie into the question early on. I think we need to start working on research. Yes, the goal is to aim high to do RCTs. Perhaps we can start baby steps, more small steps, to look at simple research, even qualitative research. By talking to patients, we can really appreciate a lot of information. We can collect a lot of important information. And then we can do some case control studies. And then once we're able to identify there's some interesting phenomenon, then we can pursue and look at a more rigorous way of evaluating that question using RCT design. Perhaps getting more people to be involved, and getting more resources, getting your industry partners. A lot of people think that getting industry support it's going to bias the study, but it's really, at the end of the day, is about the study design that will help to improve the rigor of your study. As I said, by introducing blinding, by introducing randomization, we can actually be more confident about the findings, whether the study is sponsored by someone or not. So I think it's really about our scientific integrity in the process of doing research that will make a difference. There's another question about people with temporary stoma could experience anal dysfunction. Are there any recommendations to avoid this complication of the lack of pelvic use during the active stoma time? If I understand the question correctly, yes, I think depends on the type of stoma and if the rectal stump is still intact, so people can still have discharge from the rectum. Absolutely, and you point out one of the gap that we actually have not really discussed so far, that potentially can be put into a research question for further inquiry to really understand the impact of some of those discharges on quality of life and things that we can do to prevent and to address the perianal problems. Is it possible to apply ceramides on the skin when we do not have the barriers with ceramides? I would think so. I don't know what kind of formula you have that your ceramide can, the vehicle that carries the ceramide. So if it is a cream or ointment, again, it can affect the barrier adhesion. But if you have something that is not going to affect how the barrier can stick and stay on the skin, potentially, absolutely, by topically applying the ceramide, it potentially can protect and improve the quality of skin. I think in the future, we can even think about different types of formulation. There's some tantalizing thought about using antioxidants agents. When we think about skin health, whether, for example, like vitamin E, other type of skin barriers potentially can maybe build the skin and improve the skin structure. Understanding a lot of peristomal skin is so fragile and undergoing atrophy because of the disease processes. So I think that potentially is another area for us to delve into from a research perspective. But I think we need to think about things that we can apply on the skin that doesn't have oil, doesn't have a lot of water that would affect the adhesion. So I still come back to that point about being more innovative. And of course, when we address some of the peristomal skin damage, we may use a puffer using the inhaler to deliver anti-inflammatory agents, and that's been very effective, but very, very expensive even for us. So it cannot be a long-term solution. It may be a short-term solution for a very, very complex problem. So I'm hoping that in future, someone will be able to deliver something similar to a puffer or inhaler that can be delivered and stay dry on the skin, or in some kind of a micro nanoparticles that has the active ingredient protecting the skin, but does not interfere with the barrier adhesion. Anyway, that could be interesting. So perhaps that was the comment about nanoparticles, lipids, and do not interfere with barrier adhesion. Exactly. So I think someone actually have mentioned about this already, so I didn't read that message earlier. So great, excellent. So I think that requires some really good evaluation to determine whether some of those nanoparticles would be effective in promoting healthier skin and prevent some of those complications from developing. What is the minimum content needed to train nurses for stomal care? Another great question. I'm hesitating because what we have to think about is globally across different associations to develop this core competency. And we think about what are the key competency that we need to develop as ET nurses, first of all. And there's been a lot of debate in the literature and in my country about what constitutes a wound care nurse, a wound specialist. Is it about education? When you get a master's, PhD, are you a wound care specialist? Well, I would say no, because you can be very research savvy, but if you don't do clinical work on a regular basis, you may not have the clinical acumen to be able to help you achieve and address the problems that we see in patients with stoma. So and that's why that's the debate. And is it about experience? Is it about training? Maybe, but at the end of your training, not everyone is a wound specialist. Not everyone become an expert in stoma care either. So what really is what are the key attributes of being an expert or being a specialist? Continue to be a huge debate globally across different associations. I don't think there's an easy answer for this very, very important question, first of all. So I think perhaps we need to have a more global effort to come together with WCET, for example, to think about what are the core competency set or the attributes or the values that we would expect the specialists to have when they're doing the clinical work. Then we can think about regular nurses. What do they need to know to provide stomal care? Well, I would think that for individuals who provide care, just like wound care, they should be able to identify problems. But even for a lot of the ET nurses, a lot of stomal nurses, they may not always be able to identify the problems effectively. That's part of what I often lament about the not just about education, because you can read the book, you can look at the slides, you can understand, you may have the knowledge about what a pyoderma gangrenosum is, but until you see a patient with PG, until you have the experience of working with patients who had PGs, you never really understand what that is. Just like, you know, unless you have done a compression therapy for people with venous leg ulcer, just by reading a book about compression therapy does not make you a compression specialist. So that's really part of the challenge of helping nurses to acquire that knowledge, to identify the problems. And a lot of times in my practice, I'll be more than happy if the nurses know how to change the pouch. Because the knowledge level, it's so sporadic, it's so variable these days in my country, because especially after the pandemic, there's a lot of a huge nursing shortage. A lot of the nurses have retired. A lot of nurses have gone, have left the career, have left nursing as a profession because they're very tired. They don't want to do nursing anymore. So we have a huge nursing shortage. A lot of the new nurses graduated from the program. They have never seen a stoma before. They have never, they don't know how to care for a stoma. So if you ask me what's the basic thing that I'd expect the nurses to do is, as basic as just to change the pouch appropriately, how to cut the opening appropriately to prevent some of the peristomal skin complications, I'll be very, very happy, honestly. So it seems like those are all the questions. Great questions, and of course they were big questions. It's not easy to come up with an answer to all those questions, and that's why we need to continue with the debate, continue with the conversation, and we need to do more research. I would challenge all of you to work with each other, work with all the professors here, and think about some of the interesting projects focusing on peristomal skin. And hopefully some of the material in the presentations give you some sort of trigger some new ideas, what research areas and what research questions that you can pursue in the near future.
Thank you very much, Professor Kevin. I agree with you. It's necessary more research in this area, especially in peristomal complication, peristomal skin complications, because as you told us, how much cost to prevent and how much cost to treat a big complication in peristomal skin. And quality of life of patients and pain and others. So it's necessary because we have many technologies, good technology to prevent, but a lot of these technologies are expensive. But it's necessary to do this kind of research to demonstrate how cost to prevent and how cost to treat. So thank you very, very much. And obrigada a todos que assistiram, estão aqui com a gente. Muito obrigada.
Obrigado. Thank you so much. Thank you for the opportunity for me to present again. I hope you enjoyed the presentation and the conversation. I've learned a lot every time I'm here to talk to all of you. I hope to meet each one of you sometime, and we'll create some of those opportunities, hopefully. Thank you again. Have a good evening.
Good evening. We thank you very much.
Good evening. Depois eu queria pedir, professora, para o pessoal que esteve presente do nosso grupo aqui, que parece que tem pessoas que não eram do grupo, só para mandar os nomes no grupo.
Eu não conheço, se pudesse
eu também não conheço.
Eu sou Ana Lúcia, da Universidade de Brasília.
Ah, Joia, bem-vinda.
Ah, tudo bem, prazer.
Prazer.
Prazer. Porque como aqui estão as pessoas do grupo de pesquisa, eu não reconheci pelo nome.
Não, é porque eu sou do grupo aqui dos estomaterapeutas que foca aqui no grupo, lá em São Paulo, aí eu recebi o link, aí eu entrei.
Tá.
Joia, tudo bem.
Não, tudo bem, é porque foi o link do YouTube para os externos, e aqui nesse link do Zoom está do grupo de pesquisa da escola, né? Por isso que eu não tinha reconhecido, mas ótimo, prazer, Ana Lúcia.
Desculpem interromper, Zé, você precisa parar a transmissão no YouTube porque eu não consigo. Lá em cima